so I get the opportunity through this baton pass to talk today about some strategies for really navigating another big comorbidity with mental illness, and that is substance abuse. And so I hope that you all will walk away with a better understanding of emerging trends that we're seeing, particularly in Florida. I think when we set up the program, we didn't know that it would be so attractive to people from other states. So I'll tell the Florida story, and then also make some inferences to things that are happening across the nation, as well as discuss some things we have to think about as it relates to comorbidities between mental illness, substance abuse, what we can do in terms of assessment. And I'm going to touch a little bit on some treatment opportunities, but would rather give you some insight on some screening and assessment methods to think about. And then hopefully you'll walk away as pharmacists kind of knowing where we fit into all of this. So I was driving home yesterday from work and passing a corner store that actually had these big, huge signs with kratom and CBD and all kinds of things, all of these illicit substances. And I'm thinking, wow, things are just so different from, 10 years ago or 15 years ago. So I will say that the issue of substance use is certainly more popular and well accepted, but it has unfortunately caused a lot of the trends I'm going to share with you. So, for example, the good thing is that we don't seem to have as many people dying from overdose from some of these substances. When we look at what's happened, particularly right before or during the pandemic to now, we're starting to see a downward trend as it relates to overdose deaths related to either cocaine and heroin, our opioids, psychostimulants, etc. But in that, there lies behind, some backstories that I'm going to talk about. So, for example, if we look down at this brighter orange, this represents the use of phenylethylamines, which are like our love chemical things, substances that are commonly used at like rave parties and those kind of things. And then we start noticing the fentanyl compounds were very popular back in 2018, maybe compared to some of these other categories. But if we look 3, 4, 5 years later, we start seeing this upward increase of some of these same substances, with fentanyl seeming to kind of take the lead. And so this has been very concerning in the world of substance use and abuse. Also, our depressants and tranquilizers have grown in number also. So when we look even further at some of the drug queries, what we notice is that our stimulants like methamphetamine, dipentalone, and isopropylbutylone, those are increasing, and fentanyl is right behind them. And some of the challenges is that our ability to detect some of these systems has been slower in happening than what we're seeing happening with some of the trends. So we're going to talk a little bit about what this looks like and what this really means, but I just thought I would kind of share this with you. So what's been happening at the I'll say the police level or surveillance level is that there's been attempts to develop surveillance programs or kind of make our ability to detect these substances a little bit more sophisticated, because the emergency rooms were running over with people that were obviously euphoric on substances, but we could not necessarily hone in on what the substance was. So there's a program now available called Detox, where they are actually able to test for substances and be able to hopefully hone in on what people are using. And the DEA is actually covering the costs and all this. And this is allowing us to get a better handle on being able to report these numbers back, so that people are aware of what's out there. Still hasn't been, I'll say, mastered, but we're definitely doing a lot better than we were, say, about 10 years ago. And we look at the last quarter of 2024, we're noticing fentanyl and some of its other congeners seem to be probably the most popular substances and overdose cases that have been analyzed. But again, we're still trying to catch up in terms of being able to detect these substances. Now, Florida, Pennsylvania, Massachusetts, what we find is that we've got some novel substances that are popping up in these states, as you can tell by the different colors. So I'm not quite sure whether why the parties are in these states, but in Florida it's very concerning. And partially because we have such a large population of snowbirds and retirees. We have a very diverse population in terms of ethnic groups and different practices in that regard. And so we're noticing that some of these new substances seem to be surfacing here. And then, as I mentioned, some of our northern states, we're also seeing patterns. Out west, there seems to be a pattern with the orthomethylfentanyl, but nonetheless, all of these stimulant and fentanyl congeners seem to be increasing across the nation. And this was just last year's data. So this is something that we're paying attention to. It does appear that still our deadliest combinations are those substances that are used with fentanyl and heroin. Interestingly, as we've looked at the opioid crisis and some of these other issues with substance abuse, we're seeing that it is still very, very popular, but fentanyl is so much more potent than heroin. And so when we start noticing these fentanyl-like derivatives being developed, it is very concerning. Fentanyl is extremely, extremely addictive. When you look at its pharmacokinetic profile compared to heroin, unlike heroin, it doesn't seem to have a change in the half-life or duration of action like what we were seeing with heroin. And so that makes it a little bit more appealing. We also know that we have various formulations available with fentanyl, which makes it also a risk for our pediatric population to, if they were to see a fentanyl lollipop, for example, they could very well mistake it as a regular lollipop that's in the store. So we do have some concerns in that regard. And when we have other fentanyl derivatives like a carfentanil show up, we do see that we again have even more potency with it compared to fentanyl. So, in terms of heroin and fentanyl and drug seizures, looking at this 5 year glance, we saw what appeared to be a decrease in heroin and fentanyl, both in those drug seizures, which is actually assuring. But some of that, again, we're noticing we have these other substances that have been more prevalent in some of the drug seizures. And these are examples of some of what's being found, some of these fentanyl analogs, and then the nitazines also have been kind of surfacing also. So particularly in Florida, protonitazine, metanitazine are things that have been surfacing in some of the drug queries. And again, what they bring to the table is even more potency than what we have with fentanyl. So to kind of retract, fentanyl is much more potent than heroin, and these new congeners are even more potent than fentanyl. So this is actually terrifying when we talk about what that's going to mean in terms of the substance abuse picture. Some of the nitazines, we are discovering that people have used them, unfortunately, after they actually die. And so, again, that is feeding some of the numbers of why the overdose deaths seem to be decreasing with some of these substances, but they're increasing with some of the newer ones. So these nitazines are actually synthetic opioid-like congeners that, again, are contributing to the number of overdose deaths that we're seeing. And unfortunately, our opioid screens aren't sophisticated enough to detect them as much as we'd like. And again, the potency compared to fentanyl is good for the user and abuser, but bad as it relates to some of the outcomes that we're seeing. Certainly in 2024, I just kind of documented that in the first 3 months of the year, there were over 50 cases of nitazene overdoses where only 4 individuals lived, despite attempts to try to sustain life through the use of naloxone and drips and intubation and the like. So these are some of the challenges that are taking place in our substance abuse centers, our emergency rooms, etc. And so we really have to get on top of this. Another substance that is troubling is xylazine. And it is a drug that actually is used in veterinary medicine to really help sedate animals, and it's an analgesic, it's a muscle relaxant, etc. But unfortunately, humans have been using it, and the pictures that you can see here shows what looks like it basically creating like skin ulcers, almost as if it's burning or eating the flesh. And so we were noticing headlines from emergency room visits where they would see individuals that would be extremely, extremely high, but because of the effects of the drug, they wouldn't even be bothered or feel the pain that normally would be associated with what we're seeing in these pictures. And in some cases, limbs and stuff have had to have been amputated, but because the drug was serving or providing an analgesic effect, it didn't require, or they didn't seem to be, again, experiencing some of the pain associated with what would be a very traumatic experience. So this is, horrifying to think that people are using this. They're using it in combination with fentanyl. And what we see is that it is actually expanding or extending the euphoric effects that fentanyl is causing in the individual. And so, again, this is extremely concerning. And when we look at drug seizures, just in 2023, again, we see this highlight in Florida, Pennsylvania again, and even Ohio and a few other states. So the darker the blue, the more more states were reporting seizures that actually had xylazine as a substance that was identified. So again, very, very concerning to see this as an emerging trend. What we notice is that it's available as both a pill and a powder, but the powder appears to be the probably most popular one, the one that is increasing in terms of us being able to find it in samples of drug seizures. And so again, just wanted to make you aware that people are using it in different formulations, but that the powder seems to be the more prevalent. So and before we continue, I just want to take a moment of pause, not to say I know everything about these substances, but that these are some of the things that are popping up that are causing clinicians like myself to have to really kind of stay up on our game. And for those of us, all of us, most of us are pharmacists, and we spent a number of years to get our degrees. But what we're noticing is, I call it the street pharmacists seem to have a head up on us because, or a leg up on us, because they're able to modify the chemical structure of some of these substances, and subsequently we're seeing a lot of issues in terms of these new substances emerging that are much, much more potent than some of the substances that we previously had. So if there's any questions, this will be a good time for you to put them in the chat. I don't think you'll have the ability to unmute yourself to actually listen, but I'm going to start asking a few questions myself to see what you gather. So feel free to use the chat if you have any questions. So naturally, technology would say, let's take a little break and start over. And it wants to freeze on me. But any questions? I don't see anything in the chat just yet. Let me see if it'll. Okay. Mr. Jackson, I might need your help at some point if it doesn't want to.
Sure, I'm here for you. What do you need?
Okay, I'm going to try something else and see if it'll advance this away.
Okay.
Uh,
And by the way, while you're doing that, the session code for Mr. Massey's presentation is FE96. That's Foxtrot Echo 96. And
Okay.
we put the code in the chat too.
All right. Well, looks like I might be back in the game now. So we kind of talked about xylazine. We mentioned fentanyl, where we are with heroin, and some of these other things. And I just want to remind you that the the old-fashioned substance abuse patterns like alcohol use and tobacco, hallucinogens, benzodiazepines, all of those are still ever present, and that most times individuals are using more than one substance, and it's the combinations that really are concerning. So we don't want to lose sight that as we have these emerging substances, that this issue is going away in any sense. But let's kind of continue this conversation about some of the emerging things that we're seeing. So as I mentioned on my way home, I saw this flag showing kratom as a substance that was for sale in a gas station. And this is actually a plant from the Asian countries that can be chewed, made into a tea, or smoked. And it actually has been an alternative for users that are going through opioid withdrawal, and also as an analgesic or pain medication. So kratom in and of itself, like most of these substances, has the unfortunate ability to cause some drug interactions and stuff. So this is something we need to pay attention to because these products are metabolized by the body, just like a prescription product would oftentimes. And so here, when we start seeing cytochrome P450, 3A4, 2D6, we do know we have a large number of medications, namely psychotropics and other chronic meds that are being metabolized by these isoenzymes. And so we have to make sure that we are evaluating and paying attention to concomitant medication use in these patients. And unfortunately, we are seeing overdose deaths associated with the use of kratom. And I just commented on some numbers that were shared between 2013 and 2022. And unfortunately, it's legal to buy. So we do want to make sure people know that in the state of Florida, it's in a Schedule 1 drug, but the different formulations are legal. However, typically the safeguard is that if you're 21 or older, you're the only ones that can actually purchase it. But again, that access is what is concerning. What we see is that when individuals get addicted to kratom, it looks much like what we see with other substance abuse. There's physical effects, psychological effects, as well as social and functional effects. When we look at some of the deaths that have occurred, what we see is when kratom is used in combination with other substances of use, we are seeing more deaths. And this was as late as 2022. And so, again, this is something that we are definitely paying attention to. So, again, whereas deaths with opioids and heroin may be going down, we're seeing an uptick with substances like kratom. Another class of drugs that are concerning are the stimulants. So we know we deal a lot with the ADHD drugs, particularly methylphenidate and some of the amphetamine-based drugs, but methamphetamine is still a very popular emerging substance of use and abuse. And then we have our nicotine and caffeine, we have our bath salts, cocaine. They're still around and still very problematic. So, with that, I want to just kind of do a really quick knowledge check to see if you remember what I said about which substance is commonly used in veterinary practice. So, you can use the chat if you want to. I don't think Dr. Jackson at this point will employ the poll. Seems like a lot of them are going ahead. So, I see a lot of C's, which means that people are paying attention, even though my slides want to freeze up on me. All of you have gotten the right answer, so I'm really proud that you paid attention. All right, let's see if it'll move. Oh, I'm not sure what's happening. Feels like I'm on a substance this morning. Okay, let's try one more time. I'm going to just stop sharing. All right, so yes, the substance that is used in veterinary practice is xylazine.
Dr. Hill,
Yes, ma'am.
I think there's a hand raised,
Okay.
and do you want to go ahead and answer that question, or do you want, I'm sorry, do you want us
Yeah,
to
yeah,
allow?
let's answer the question. I'm gonna try to get my slides going again. Was it Mrs. Rowena that asked the question?
Yes, let me see if I can pull her up so she can ask her question.
And while I'm answering her question, Mr. Jackson, I might need to go ahead and get you to be my Vanna White, please.
Okay, I'll go ahead and
Okay.
get started on that.
Okay. Miss Colston, good morning.
Uh,
She'll have to unmute her microphone.
You have to unmute. I won't be able to unmute you. Yes, ma'am. Yes, ma'am. Uh-oh, maybe
Yeah, we're
her.
unable to hear her.
Yeah, we can't hear you right now. Did you want to put your question in the chat, maybe? Okay. All right.
All right,
Well,
let me see
Mr.
if I can bring
Jackson,
your
no
slides.
question. Oh, okay. Okay, great. Well, good morning. Good morning. You're just stretching your arms. So, Dr. Jackson, if you are you going to be able to pull
Okay.
up your slides? Okay.
Yeah, give me a second here.
Okay. So yes, with xylazine, as I mentioned, unfortunately, people are experiencing that what looks like flesh-eating experience. So did anybody see any of those headlines? I know probably about 10 years ago was probably about the first time that I heard that. And I was thinking, oh my goodness, how addicting a substance would have to be for you to still use it and you see yourself with these ulcerations and all that kind of stuff on your body. So I think our next question, I wanted to kind of see if you were paying attention to one of the other substances that I talked about, but we'll see if the technology will allow us to kind of move on.
Just give me a second. I'm trying to find the last slide that you had.
Well, I'm going to actually ask anyone to put in the chart, the chat, if you are currently working with individuals with substance abuse issues. And just you could just put a yes or thumbs up or something like that. And then I want to ask, I do see Ms. Clark. Okay, no, no. Okay, good, good. All right. Well, you're fortunate if you haven't. And how many of you have dealt with people that have mental illness? Because again, that's what we're here to kind of talk about today. Okay. Okay. All right. So as we get through, we're going to stop talking about the substances and transition a little bit into the mental illness piece, because what I really kind of want to point out today is how sometimes it's hard to actually be able to recognize the difference. So I think we were a little further along, Dr. Jackson. I can see the slides up now. And I think we had gotten to our first poll question. So the next question. And we do thank you all for your patience with this. Technology is great when it works, right?
Yeah, tell me when the need to stop.
You can back up now. You kind of actually passed past us. Yeah, go back about. Okay, stop there. Go there. Next slide.
Okay.
Next next slide. Yeah, the next one. Hmm. Okay. Well, why don't we'll start there. We'll start there. That's a good place to start. So what I want to point out, and I think I just want to kind of set the stage for Dr. Rappa. He's going to talk about the medications and stuff that we use on the mental health side. I put this table in the presentation just to remind you the function of the neurotransmitters and where they are throughout the body. And what we see is this interplace of their function in the brain. And then I want you to really understand why it is that people who have behaviors where there's substance using is partially because of the impact on these neurotransmitters and what they already do. And in the next slide, I kind of show you how pictorially norepinephrine, serotonin, and dopamine actually assist us with memory processes, with mood, other physiological processes. And sometimes it's even hard to distinguish if it's just noradrenaline or serotonin at play, etc. So he's going to do a much better job talking and a much thorough job talking about, the role of those medications. But in the substance abuse area, in our next slide, I show you a brain that actually pictorially explains where these dopamine pathways and serotonin pathways are also inherently involved in the addiction cycle. So all of our reward processes are attached really to dopamine function or dopaminergic activity. And serotonin also plays a really good role in that. But really here, what's happening is that the front part of the brain, that frontal cortex, actually is being modified to a certain degree in individuals that are using these illicit substances. So in the next slide, there it shows some more deeper or deep brain organs like the VDA and the nucleus accumbens that actually are they innervate or feed function in the prefrontal cortex. And that drives some of the cravings and desire for us to actually use and abuse these substances, despite the fact that logically we know they're harmful to our body, they're addicting, etc. All of this kind of sets off this cascade of Feed Me Gilmore, if you ever watched that movie Little Shop of Horror. So let's go to the next slide, Dr. Jackson. So I kind of like to try to paint that picture of why addiction is so hard. Because if we go back to the simple days of tobacco use, back when I was a teenager, smoking was the big no-no, right? And it was considered one of the more major gateway drugs, as was marijuana. But tobacco still continues to be one of those the highest preventable health diseases out there. But we still have a lot of people, unfortunately, who report that they're using tobacco. And now what's happened is we have this big smorgasbord of different types of tobacco products. So the burden that I wanted to kind of point out is that in our 18 to 24-year-olds, they have kind of shifted to e-cigarettes, and then we see the highest prevalence of smoking the traditional cigarette taking place in the 45 to 64-year-old age group. Next slide, Dr. Jackson. So what this means, as I mentioned, it's already a burden in terms of death and disease, primarily because you've seen the public health campaign that tells you smoking kills. You know, we've seen, unfortunately, where people develop lung disease or lung cancers. And despite, all of the massive education to try to get people to stop smoking, people are still smoking. And it's costing a lot as it relates to healthcare costs. But again, approximately 25% of people have some form of mental illness that we're not quite sure if that's driving why they're smoking, or if it's the other way around. So when I was at Florida State Hospital, oftentimes when we had people with substance abuse disorders who were also mentally ill, we referred to them as dually diagnosed. And so the way we approach that patient is having to really pull out all the big guns, because oftentimes they were using these substances to try to, in essence, feed or self-treat whatever mental illness that they had. So the issue is that most of our mentally ill patient, large number of them, particularly in severe mental illnesses like schizophrenia, we do see a very, very high prevalence of smoking take place. So Dr. Jackson, could you show them the next slide, which actually kind of shows you, as I mentioned, this smorgasbord or menu of choices that people have now beyond just the traditional cigarette. So as we know, the cigarette actually has tar, and it's gotten a lot of bad press because of all of the toxins associated with it. The pipe used to be definitely something associated with, a certain level of status. And now we see cigar bars being very, very popular. And again, another source. And so the conversations of not only secondhand smoke, but now there's third-hand smoke, where we, really are recognizing that there is still risk for us to be exposed, whether we're using directly or indirectly or just being around people. It used to be, I remember having classmates that played baseball, softball, that, may have enjoyed some of the nicotine troches or use the oral products a little bit more, and we just associated that with the fact that they played baseball. But we see now that there's just so many things that are out there on the market that are attracting to people to look. So let's look a little closer at tobacco and its metabolic profile. So in the next slide, I kind of show you that nicotine actually is also very important in the body. We know we have nicotinic receptors that are primed to actually modulate acetylcholine functions, but it actually does go through the liver for metabolism. Nicotine actually modifies sometimes certain liver enzymes, particularly 1A2. And depending on the route of exposure, that determines how quick it gets into the bloodstream. And so that's where it can be problematic. Most damage typically from smoking is also felt in the lungs, but we do have other organs that also can be unfortunately affected by exposure to nicotine. So I'd just like to remind people that it does work physiologically in the body and actually supports or is a part of all of the things that we see acetylcholine doing. So from memory processes to, again, I call it assisting with lacrimation and those kind of things that acetylcholine does. So this is really important. So let's go to the next slide because I want to point out some of the benefits and the limitations, but first understanding a little bit more about receptor activities. I already said nicotine mimics what acetylcholine does, but it also stimulates dopamine release, which is that pleasure piece that oftentimes is the reason why people use substances. The challenge that we have with substances that are used and sometimes misused or abused is that most times they're stimulating that receptor presynaptically. And most of the drugs that we work are used are working postsynaptically on the other end of the neuron. And so oftentimes users will just increase the amount that they use to get over that tolerance hump and avoid withdrawal. And that's that addiction behavioral cycle that I kind of alluded to earlier. So that is the challenge that dopamine brings to the table because it's being stimulated. We're setting off those dopaminergic pathways and again making the brain hungry for this chemical. Norepinephrine is also stimulated, and we know it's very associated with cardiac functions, et cetera. And this kind of explains why we see some of the medicinal fallout that's associated with nicotine use. And so we have to be also mindful that it can increase an alertness, but it also can cause things like anxiety. It can cause tachycardia and other things, and even contribute sometimes to the prevalence of things like panic attacks, et cetera. So that's where it's concerning. Cognitively, there are some benefits. So let's go to the next slide, Dr. Jackson, and I can actually point out that it does, in turn, with some people, though, calm them down, which is why you have some of the individuals, they get wired up, they go have a cigarette. I had one patient that every time her and her husband made love, when she finished, she'd go have a cigarette, except when she got pregnant, that she would just stop altogether. But then once the baby got here, she'd get stressed. She decided not to breastfeed so she could go back to smoking. So you see the powerful draw that the nicotine can actually have because of that dopamine release. But it does reduce stress and anxiety, improves cognitive sharpness, which is why we've looked at it, particularly in the space of Alzheimer's disease, and it helps with alertness as well as concentration. Now, the downside of that, I kind of show in the next slide, where we end up with a lot of physiological processes that occur. So some of it looks like altered pain processing or structural damage elsewhere in the body, but there's a lot of psychosocial factors. Depression can actually occur, and then interaction, obviously, with other drugs, particularly the opioids. So sometimes, again, though it may be helpful, this is the baggage that comes along with using tobacco. So if we look at what this looks like at the receptor level in the next slide, I have just another picture to kind of explain a little bit about the mode of action. And as I mentioned, we have some presynaptic and postsynaptic processes that are taking place with nicotine. And again, all of this acetylcholine, dopaminergic, and noradrenaline activity actually is why we end up with this overarching issue with tobacco. So in the next slide, I kind of show you how the acceptance and evolution of e-cigarettes came about. And interestingly, I'm not sure if you were aware of two things that Herbert Gilbert actually made the first version back in the 60s, but the one that probably has become the most popular was made by a pharmacist. And this is not surprising. Pharmacists have always creatively done things to try to fix the ills of society or help in medicinal purposes. We've made things like Pepsi Cola and stuff in attempt to try to help mitigate some of the issues people were having with gastric distress. And so this e-cigarette was actually made by this Asian pharmacist, and actually it is beneficial. It one pleases the oral sensation associated with smoking without some of the issues as it relates to the vapor and the exposure to nicotine. It's not absolutely perfect though. And so I wanted to kind of show you in the next slide that looking at an animal study, what we did find, well, it'll be the next slide, but let me show you this slide first to just show you that compared to the regular cigarette, what we see is that the e-cigarettes amongst ages 12 to 17 is probably the preferred thing. And I mentioned that a little earlier. So hookahs at the top, followed by e-cigarettes. And what we see is the traditional cigarette is way down at the bottom for this particular age group. So what this really means and how I want you to interpret this is all the public health campaigns that went forth for tobacco use were effective in deferring the use in that particular age group. So that's good. The problem is that the younger individuals are using some of these other formulations as their substances of use. And so the numbers clearly say things like smokeless tobacco, the pouches, all of that are still popular. But everyone got the message that the nicotine and the tar and the menthol and all that kind of stuff is problematic. And so they're resorting to things like e-cigarettes. So now we'll look at the slide where I show you that there was actually a study done in rodents that said that basically we do see those same changes in that frontal cortex from the use of the e-cigarette. So it's almost parallel to what we're seeing in the cigarette. So this is why I say that this is not necessarily the perfect solution. It does help defray some of the oral cravings and things for individuals who have smoked for years. This does give them something to put in their mouth besides food, because oftentimes that becomes the resort that individuals who have previously smoked, they start eating too much. But again, this study definitely suggests that we might see some of the same issues because it's not totally nicotine free. Okay, so let's go to the next slide. So some of the long-term cognitive effects that are associated with smoking I have listed here. Why is this important? Because one of the spaces I've spent a lot of time in, actually, those of you that know me, has been Alzheimer's disease. And I oftentimes see so many people who've had a history of smoking or are still smoking, and I've got to try to figure out a way to have them consider stopping because there is an increased risk of dementia. There were some studies in nuns who, by the way, none of them really smoked, but compared to the general population, they had a much lower risk of dementia because they didn't smoke supposedly. And so that kind of took us down this pathway of appreciating some of the cognitive benefits of smoking. But on the flip of that, because of all the other challenges I showed you in some of the previous slides, we have concluded that there's actually more of an increased risk associated with dementia because it does affect processing speed, attention, problem-solving abilities, and some of the other things that I have listed on this slide. So next slide, please. So the reason for the risk: impairment in short-term memory, decline in long-term recall, and then diminished learning capacity. And when you fold that on top of some of the other risks like genetic risk factors, age, or gender, then certainly those things we can't change, and that makes it worse. And I haven't even started talking about other comorbid things or chronic issues, where individuals who've had strokes and the like becomes an issue. So I do see a question, Dr. LaRose, as it relates to how much nicotine. It depends. It's certainly much less than what we see in a normal cigarette, but it is enough to definitely, again, cause these changes in frontal cortex. So it depends. They have become very sophisticated with the e-cigarette like they have with some of these other formulations. So sometimes it's a function of how much the individual is using, how long they've been using it, how old they are, and other things in terms of the impact, but it is less than the standard cigarette. Yes. Okay. All right. Could we go to the next slide, please? So this slide kind of basically shows you really, the connection between smoking and mental health. On one hand, it causes or it makes individuals calm, less anxious, but it might make some people more anxious because of the impact on and the impact on cognitive function. So again, there's this never-ending cycle. Every individual is very different, and so it's just really kind of hard to say what's gonna happen with that person if they're smoking a pipe, if they're smoking cigars, if they're smoking cigarettes. What we just oftentimes see is just as much issue with depression and anxiety being helped as it is harmed. Okay, so I think it's time for another knowledge check. But want to see if there's any more questions before we move a little further. Okay. Okay. Hopefully, Dr. LaRosa, I answered your question enough. All right. Well, I don't see anything else yet, so let's
Yes,
move
you
on, Dr.
did. Thank
Jackson.
you.
Okay. All right. You're welcome. Great, great, great. Okay. So I've said a couple times that people are smoking less, and I kind of commented on the 12 to 17-year-olds, particularly being a little bit more interested in things like e-cigarettes and all. The other thing that they're interested in is vaping. So as smoking has gone down, the incidence of vaping or daily is going up, and which is indicated in this picture with the orange color. And so this is actually kind of concerning also that now we have more people vaping. And so we need to spend a little time talking really about what does that mean in terms of pros and cons. So in my next slide, I kind of compare the cigarette to vaping. So on the cigarette side, there's over 200 toxins, and we know people have a real struggle with trying to quit. Oftentimes, on average, the individual might have tried 6 or 7 times before they successfully quit. Then you have those one-offs where people just wake up and decide, I'm not going to smoke anymore, and they don't. Or you have scenarios where they're highly encouraged, like in the case of the patient I told you who, when she got pregnant, something went off in her brain to make her realize she didn't smoke anymore, but then she later would resume. Or you have some people who recognize, well, now I'm ill and I have things like cancers or I have other lung disease, and they also stop. Compared to vaping, vaping doesn't expose individuals to as many toxins, but people do struggle with trying to quit as well. So there's a role for us in terms of helping, and we have to just think about smoking cessation in a different light. Certainly, vaping is cheaper than smoking as it relates to definitely just securing the product. But in the next slide, I kind of point out that there's additional challenges with vaping, like manipulating the device sometimes isn't as beneficial. People still develop things like allergies, and other people are exposed because there is still sometimes a little aroma or vaping. But overall, there are some advantages to vaping versus the standard cigarette, and I do apologize that the graphics in this slide may not be as easy to read. Hopefully, you can decipher them when you look at your handout. And if you have any question, feel free to reach out to me and I'll be glad to kind of explain. So again, this is something we need to be aware of because individuals are vaping. And the other thing we have to think about is as we knew there was a big move as a part of the public health campaign to minimize the amount of smoking in public places, a lot of individuals shifted to vaping and they try to be a little bit more discreet in doing it. But again, there are some concerns about secondhand exposure from people who vape, and there are still, inherently concerns regarding that. So as I move on to the next tobacco type that's popular, I just want to say one of the things that vaping offers as well as hookah is flavoring. And that's what is contributing a great deal to why we're seeing such a higher prevalence of use and abuse with these particular substances. So I was first introduced to hookah was through a cultural experience. I had a preceptor neurologist who was from Egypt, and he had a party, and traditionally in their culture, they would pass the hookah around. I didn't participate at that time. I was just intrigued by the beauty of the apparatus and all. And what you notice is you have a hose, you have charcoal as we use for barbecuing, you have water, etc. There's a mouthpiece, and I was just turned off by the fact that people are sharing the mouthpieces as they pass this around in their ceremonial way. But hookah actually, again, you see it embraced in a lot of different cultures, but it allows an opportunity for you to incorporate different flavors, and it does give a very similar high or euphoric effect, much like a tobacco product. So the difference here is we don't necessarily have menthol involved, but you do actually have some exposure using that charcoal. That charcoal becomes your heat process and it heats the water. But the water isn't cleansing it of anything. And so inherently there's some concerns. So we go to the next slide. I wanted to tell you how potent hookah is because compared to a cigarette, 1 hour of hookah smoking is equivalent to 100 cigarettes. Now, who remembers how many cigarettes are in a pack of cigarettes? When we buy cigarettes, how many cigarettes are in there? But you can use the chat. Yes, 20. So that's 5 packs in an hour equivalent. So I've already kind of pointed out some of the challenges with using cigarettes. So this tells you the extent to which hookah can be even more problematic, right? Now, I don't want to minimize cultural traditions or anything. I'm not by any means judging any of that, but there are inherently some risks. And it's just become so popular. And I don't know about where you live, but I know in Tampa we have quite a number of cigar bars, hookah stores, these vaping stores, these smoke stores. So if you're seeing that in your area, put a thumbs up so I can see and wonder if it's just a Tampa trend that's going on. But I know we do have a lot more of these kind of stores in our area, and they've become extremely popular. And I've already kind of talked about nicotine and some of the issues with metabolism and what happens. So just imagine what a hundred cigarette exposure in an hour looks like. Okay. So in the next slide, I wanted to kind of show you just again some other comparisons between hookah and cigarettes. And oh, okay. So Shanita, you're seeing a lot in Pensacola as well. Interesting. So what we're talking about in terms of the tar exposure is 36 times more tar in a hookah experience, and then 1.7 times more nicotine. But the carbon monoxide exposure also 8.4 times more than what you would have through the cigarette exposure. So, having never smoked a cigarette myself personally, again, it just gives you something to think about. So far we've said, e-cigarettes are more popular, and then we transitioned and talked a little bit about vaping, and now we're talking a little bit about hookah. And again, it's just scary. It's like these products are getting more and more potent, and again, we have a greater risk for causing more issues. Well, we can't forget the other gateway drug. So in our next slide, let's go ahead and start talking about the elephant in the room. We know now there's been a lot of changes in terms of regulation for cannabis products. So we got to spend some time there because tobacco has diversified. It is, we have a whole lot of formulations, but in the next slide, I'll just show you a handful of the things that we're seeing. So, in my clinics, I have a lot of my Parkinson's patients that are ingesting in the edibles, particularly they like the brownies. Some use gummies, but I see a lot of the gummy use more so for insomnia, for sleep issues. And then the brownie is preferred, particularly with the fact that a lot of my Parkinson's patients have issues with tremors and rigidity and moving, and the data does suggest it helps with some of those symptoms. And so they can come to a support group or be out in public and actually work. Now, I'm going to talk a little bit about the pharmacokinetics and dynamics of it, and why that edible is important and some of the things that we need to think about as we are interacting with patients that are using it. But just the other day, I had another patient who's using one of the tinctures, and that was how she was using it for sleep. So then when you ask the question, how often are you using it? Oh, I just use it rarely. Well, could you quantify that for me? And so I would suggest that you ask, be very intentional as you're interacting with patients to include use of cannabis and the formulation and document the frequency and quantity because there are some inherent risks to using it. But again, we've got salves, we've got juicing. And then again, you go in the average corner store, you're getting gas or you're buying your Slurpee and you'll see K2 and all kind of products at the cash register. So we have some work to do in making sure our patients understand that there are some risks. And we look at what's happening on the medicinal side. There's a list of what we call conditions that cannabis can be used medicinally. So in the next slide, Dr. Jackson, I just listed them because every state has a different list of conditions by which doctors can take a 4-hour training and they can recommend cannabis be used. And the most insulting part is that they go to a dispensary and they're bypassing us most times. The great thing is that it has been shifted to Schedule 3, which means that many of us will now, particularly in community practice, may have more opportunity beyond the FDA approved products to actually help patients understand how to use how to use cannabis, but the risks associated with it. And it's going to require us to definitely work with our providers more and make sure they're well educated. And I do agree, Beatrice, that you think the American soldiers' exposures and they're bringing this practice back with them. I think that's part of it. But I also just think that the American public right now is very open to these substances and the fact that we have policies like the medicinal regulation or lack of regulation that is increasing access to these products is also impacting some of these trends. So as we look at the medical conditions, for example, that cannabis can address, unfortunately, because of the public health campaign against opioids, right? And we are, in fact, in an opioid crisis. People are resorting to things like cannabis and self-treating, just like we're seeing with cigarettes and stuff, to address their chronic pain. Again, in the neurological disorders that I deal with, where there's oftentimes not a cure, people are a lot more open to trying something like cannabis to see if it would help. So just wanted you to be aware. I would encourage you, especially since we have a audience that's full of individuals from otherwhere. I'm intrigued and wondering what's happening in Dubai as it relates to some of these substances. But definitely, I would just say be familiar with your state regulations because every state, all 50 states, it looks different. We all have different medical conditions by which providers can recommend medical cannabis for. As I always say, the drug doesn't change. So in the next slide, let's look at pictorially what's happening with cannabis. It is interesting because we actually have an endocannabinoid system that is primed to actually metabolize and modulate cannabis. And we have different types of receptors. We're most familiar with hearing about THC, which is typically the popular cannabinoid in street versions of cannabis. That's what gives us that euphoric feeling or the high that we associated with marijuana use, or you hear individuals say, weed. But it's the other cannabinoids, the CB1 and CB2, that are modulating those receptors that give us those medicinal effects. The interesting thing about this, and I do want to in the next slide just point out that we need THC to actually activate CBD in order to give us that medicinal effect. So there's certain ratios that we have to have between the two. And the more THC you have, the more euphoria you're going to have. And so we do want you to make sure you walk away with that as a clinical pearl. So I don't know if you all remember the young lady, Charlotte Fiji. She was a young girl that was having intractable seizures. She was having literally 200 or 300 seizures a day, and she was exposed to a cannabinoid product that actually lowered her seizures to about 30 a day. So from a quality of life perspective, that's very, very impressive. So for many of you, you've probably dispensed Epidiolex, and that's the FDA approved version of that. And we also call it Charlotte's Web, which has a THC content of 0.3%. So the FDA products have no more than 0.3% of THC, and that's our way of minimizing that euphoric effect, but giving us enough to activate that CBD to give us the medicinal effect. And there's different types of species, some of which provide more of that body high or that medicinal effect than others, and then some give us more of that brain high because it has more THC, like in the case of the cannabis sativa, but oftentimes they're hybrids of these different species. So again, the walk away is we need both THC and CBD, but they exist in a ratio that allows us to benefit from those medicinal effects. So I'm gonna want to go to the next slide again, just to bring home the importance that the THC is what is providing the euphoric effect, and that the more CBD we have, the more medicinal effects we're going to have. And that's kind of what this picture is showing. I had a video, but I want to skip it because I got a whole bunch of other stuff I want to cover. And so Dr. Jackson, if you would go to the next slide after this one, I appreciate it. If it'll let you bypass that. But when you get your handout, you can actually listen at this, and it just kind of explains a little bit more about that endocannabinoid system that I was talking about. But what marijuana does when it comes into the body, again, you've got these receptors that are primed to receive it. And so it is metabolized like other products. Those THC receptors are predominant a little bit more in the brain compared to the rest of the body, but those CBD receptors again are more peripheral, and that's how we're addressing the pain, the arthritis, and other things like glaucoma and epilepsy. But depending on the route of administration and the type of cannabis product that the person use will determine how quick it works. So going back to my mention of the edible brownie, for example, pharmacokinetically, when a person eats the brownie, it may take up to 30 minutes before it works compared to someone who might be smoking, say, a joint, right? And so that becomes really important. The risk that I always have to educate my support group patients about is that don't eat a brownie when you get home and eat another one in the car in the parking lot, because what could happen is you can get this cumulative additive effect, and that actually can be very problematic. So when we go to the next slide, I wanted to point out that there are both side effect concerns with using CBD products, as well as a host of drug interactions. And I could only afford to mention the categories of drugs that could interact with CBD, because sometimes it slows the liver down, sometimes it speeds it up. And we know, and all of my FAMU graduates know how passionate I am about cytochrome P450, but we do know that if we start modulating those enzymes with these particular categories of drugs, it could inherently cause either adverse drug reactions, side effects, or lack of therapeutic effect. So the use of CBD is not benign, which is what I wanted to point out as it relates to the side effects. And then again, I want to really hone in on the fact that we could have drug interactions and that there are a lot that could occur. So far, what I've said is that we do have several substances that can cause drug interactions, and this is our wheelhouse. This is where we rise and shine and help our patients who are, in fact, using and abusing these drugs. So, some effects that go along with cannabis, depending, occur depends on how long they've been using it. So acutely, we might see some impairment in memory, attention, concentration. And then there's a tolerance that can occur when there's chronic use, which is why people tend to use more because they're trying to really get more of benefit from the cannabis products. The more they use, the more likely we're going to have those drug interactions and other issues that kind of go with it. So I want to go to the next slide to show you the effect cannabis can have on the brain because it's slowing processes and it's affecting memory. And I talked about that. So when we look at it on a PET scan, what you see over here, all of the yellow and the red, it just speaks to the energy that's happening in the brain. But a cannabis exposed brain actually slows down. So we really get very concerned about the younger the brain is because it actually can almost ulcerate the brain, much similar to what I was showing you with the xylazine. But definitely for a growing brain, like in our adolescents, we do get concerned about their intellectual aptitude. Long term, it does stunt learning processes, and I already kind of pointed out some of the other issues that kind of go along with that. But in contrast, in my next slide, I wanted to show you some of the reasons why it is a potential go-to for patients that may have a disorder like Alzheimer's disease, because it is purported to, in some of our rat studies that we've done in the Neuroscience Institute, to actually have some anxiolytic effects, as well as the ability to almost pharmacologically push out some of the amyloid beta that is associated with the pathology of Alzheimer's disease. So this is where research becomes important, and in a lot of the work that I'm doing as it relates to health disparities, we definitely need to have more individuals participate in research so that we can actually learn what would be appropriate formulations, what would be appropriate dosing, what would be the appropriate indications where we could actually use these products and really optimize the medicinal benefits of them versus us ending up with the sequelae play out in the substance abuse world the way we're seeing it. So my last point, I wanted to kind of point out what happens when people are using both cannabis and tobacco. Well, what we're seeing is a higher prevalence of things like anxiety and depression. And it looks almost about 3 times as more, both for patients who don't use at all or are using cannabis and tobacco together. And oftentimes that's what we see is the gateway. So again, I want to emphasize as you're in your patient encounters that you ask the question. But one of the ways I like to phrase it is, in light of the fact that cannabis is available medicinally, are you using it medicinally or recreationally? And and if it's okay, again, as Mr. Massey already said, we're not there to judge. We're there to support and encourage, but that becomes an opportunity for us to pivot into our educational mode. And once we can document and quantify how much they might be using, the type and formulation, then we can kind of help them get better outcomes. But what we want to do is discourage the use of the street version, right? Because there's a lot more question marks in terms of quality and other outcomes because, again, the street pharmacist hasn't studied long enough to understand and appreciate the inherent importance of having enough THC versus CBD and some of the other things that I kind of talked about. So let's do a quick knowledge check. I think we have a question, or skipping my questions, but I'm going to ask a verbal question then. And I would like to know if you all remember what neurotransmitter I said is the reason why our substance users are enjoying these substances so much. Was it acetylcholine? Was it dopamine? Was it norepinephrine? Was it serotonin? Okay. Dopamine. All right. Thank you, Michael, Stephanie, Jules. Seems like you're paying attention. Robbie. Awesome. Okay. So everybody got it. So dopamine is our really, really big issue here. And so again, we want to modulate. Who remembers? Well, I don't want to ask that question just yet. I'm going to wait on that one. All right. So let's talk a little bit about what you can do as pharmacists in your various practices, some things that you can think about to try to help with this issue. So we've talked about all these substances, some of the emerging ones, some of the more popular ones that we're familiar with. Let's go to the next slide, Dr. Jackson, and see what can we do to kind of help people. So I kind of want to set the stage for Dr. Rappa. He's going to talk about the medications, but I want you, first of all, to be able to recognize when a patient might be experiencing depression and anxiety, because sometimes it looks the same, sometimes it looks very different. Some patients with anxiety disorders have a little bit more of a physiological expression, so it might look like, worry and panic, but they might have a racing heart rate also. They might perseverate over things. Some people who are depressed, might lose interest in things. So that apathy may not necessarily be the strongest component that we see in something like anxiety, but they do coexist. And so I do want to make sure that you're very, very familiar with these symptoms and you learn how to strategically check with your patient to see if they're experiencing any of these. And I have some acronyms in the next slide that just will kind of give you, again, some shortcuts to remember on key questions to ask. And then you start asking, have you had these symptoms and how frequently have you had them over the last 2 weeks or the last month? And then you want to investigate, have there been situations like a loss of a loved one, loss of a job, or a broken relationship that could be contributing to this? But then you also want to ask that question, how are you coping and what are you doing? Are you getting counseling, or are you open, or have you considered pharmacological therapy? And then we do our piece of educating them and letting them understand what the medications can and will do for them. But I like to say if they have 4 or more of these symptoms, as it relates to any of these acronyms, that might suggest that we need some level of treatment. And if we start with nothing else but cognitive therapy, that would be okay. So the person that asked earlier about, is it appropriate to pray with a patient? Well, I would dare say that Mr. Massey would say we do what we have to do to support them in meeting them where they're at. And so sometimes, that may be appropriate and that may be a start. But embracing church and religious approaches may or may not give them the coping mechanisms that counseling offers, and pharmacological therapy offers modulation of some of the dysfunction that's happening at the neurotransmitter level. And so I've already kind of talked to you about the role and function that these neurotransmitters play in terms of mood and behavior. And so I would just encourage you to have a mixture of approaches as it relates to treatment. So also I wanted to show you an acronym for anxiety that you could also use, and it is stomach. And it just, again, kind of organizes a lot of the key physiological symptoms that we see associated with anxiety. Don't forget, you may have them coexist. And I know Dr. Rappa is going to tell you some of the things, the strategies that we think about when people are using the psychotropics, in terms of which classes are more appropriate, what side effects to expect, how long it's going to take before they start working and all that. I'll let him have that discussion with you. But I think it's time for us to have a little case. So let's look at a case and see what you all would suggest we do. So I'm presenting you with a patient that needs a little help. They're smoking and they want to stop. They've tried, quitting on their own. That hadn't really worked. And they want to try again, but they need you to kind of help them with that. They've been smoking for more than 5 years, but they are highly motivated now and want to try some sort of pharmacotherapy. And so this is what is inviting you to the party. So how would you determine what's best available for them? So when we look at all the things that are out there, we have a smorgasbord of products. I'm going to mention some of them that you can talk about. But what I would like to advocate is a technique called the 5 A's that you could use as a strategy to start out with. So in the next slide, it kind of summarizes the 5 A's that can be employed, particularly with tobacco cessation, but they're applicable with any of these substances, where you ask, assess, you offer advice, and then you assist and arrange. And so that means that we do what we do best. We are resourcers, we are connectors. We're making sure that we're evaluating what their needs are and helping them go through this journey, because stopping smoking is not easy. And I have had patients who are on oxygen and still trying to smoke. And it tells you just how powerful that draw for smoking can actually be. And so we know that they may not make it. And if you've had any opportunity to go through any kind of training, smoking cessation training, and those kind of things, you can appreciate there's a lot out there. So in the next slide, I kind of have a nice chart that shows all the different products and all the nuances associated with it. And what I would say is we address smoking cessation either as a nicotine replacement approach, and we have, from patches, lozenges, and gum, and all those kind of things, and so many opportunities to counsel our patient on how to use the gum, right, versus the lozenge, where to apply that patch, when to take off the patch, how to dispose the patch. So there's a lot of education opportunity. And I want somebody to put in the chat for me, what is the method behind using the gum? Just describe it in the chat for me. And while I'm waiting on a response there, I want to remind you that we have products like bupropion and the Chantix that help us with the cravings, right? So the bupropion is using it through a dopamine-based mechanism, and then the Chantix is doing it by actually modulating nicotinic receptors. And so that becomes really important. Now, they both have their limitations. So before someone asks me, when do I use bupropion versus Chantix, let me just tell you that some patients with bupropion were concerned about the seizure threshold being lowered and that causing issues there. And in some cases with the Chantix, I get concerned about the psychiatric disturbances. So sometimes with pre-existing mental illnesses, we have to be very selective about which of these products we use because we don't want to necessarily exacerbate severe mental illness. So yes, Mr. Cunningham, oral stimulation, nicotine satisfaction. But what I was getting with the gum is that we want to tell people to put it in, chew it a little bit, and get that tingly, right? Yep. So Todd's right on it. We get that tingling effect, and then we park it inside the cheek for a little bit. Then they chew it again, then they park it. So it's the chew, park, right? And they are going to have more than one piece of gum. We do have limits on the amount of gum that they can have, but that does allow us to fulfill that oral component of the addiction of putting something in the mouth that helps. But you're not chewing it. You're right, Glenn. You're not chewing it like regular gum. Okay. And be careful and make sure you advise them if there's children around, because we don't want them unnecessarily exposed. All right. So the next slide, I think I show you some pictures of these different products. And again, it's not a one size fits all with that nicotine patch. Oftentimes, reminding them where to put the patches and who remembers what the rule is for the patch and where it goes. Where do we apply these patches? So, Chanita, you're right. We want to mimic the physical act of smoking with the gum and the oral products. So, Marfria, I hope I said that right. You're right. We want it on a hairless area, but are we going to put it on the ear? Are we going to put it on the elbow? Where are we putting it? You're right, Anthony. A flat, dry area. But in this case, we're going to be above the waist. That's the only hint I'm going to give you. Tell me where else. I want to hear specifically. Can they put it on the chest? Can they put it on the back? Upper arm, you're right, Anna. So I want you to make sure that all of you know these sites of location. The chest and the back is also an option, but that upper arm typically works. And then what do they do when they dispose the patch? How do they dispose it? What would you suggest there? Yep, you fold it. You're right, Miss Clark. They do want it out of sight. So not on the outside of the arm, but you have to be very, very careful. So I think you all are doing a really good job. So Miss Clark, you're right. Fold it like a napkin. Sometimes I say put the sticky sides together and encourage them to save the wrapping it was in or use foil paper to put it in, and then they can put it in the garbage can. I am not a big advocate of also cutting the patches, but I want to remind you all that some of these patches are matrix patches and some of them are reservoir patches. And so we want to make sure with any patch that we are educating our patient on these kind of rules. All right. So you guys are on your way and you already are masters. You didn't need me to talk about this, but anyway, I just want to remind you of some of these things. So the next slide, again, with Chantix, it actually helps people quit smoking in multiple ways. But again, our biggest risk are some of the psychiatric features that kind of go along with the product. So now that we've kind of talked about what we can do for smoking cessation, I just want to make sure that you have in your toolbox some resources of where to advise people. So as was mentioned, I work a lot with the AHEC centers, and they have very, very good cessation programs and training. Their mission is to train learners that are in the health professions. So a lot of times their work is with individuals that are in, pharmacy, medicine, nursing programs before they graduate. So they do a lot there, but they also provide training. And if you're interested in becoming a certified tobacco treatment specialist, AHEC is a really good place to work. I know in Florida they have a strong presence. I can't speak for Georgia, North Carolina, and certainly not Dubai, but I do want to encourage you to investigate what is available in your state or come to Florida for one of our trainings. There's also quit lines that are available. And then in the next slide, I'll show you that the other thing that AHEC does very well, and the state of Florida Department of Health also, is they offer these quit programs. And it might look like face-to-face programs where they're actually in, small cohorts where they learn about the benefits and the risks, and they get almost this counseling component also attached to smoking cessation. But they also have the support of others that are going through the same journey. And with it, a lot of times they have different incentives. So like right now, our AHEC has a gift card incentive. I think in the next slide, I mentioned that they have a gift card that they're giving for people that sign up for group quit. And so again, these are some of the things you want to have these connections with an AHEC and other groups so that you can advise and draw traffic to these particular programs, and just being aware. The other thing I wanted to mention is we do have other organizations like APHA that offer smoking training. I remember years back doing one of the programs from a drug company, that one of the drug companies that coincidentally made one of the nicotine replacement therapies. So just be on the lookout. There's a lot of ways, if you're interested in credentialing yourself in this area, that you too can become a tobacco cessation specialist. And all of these things are applicable for individuals with substance abuse, although we do need that rehab component, a lot more counseling, a lot of other social determinants of health support associated with rehabilitation of things like cocaine and some of the more illicit drugs. But this is always a good place to start, particularly if individuals are smokers. So let's do another knowledge check. I think hopefully the next slide will show this. So you could go ahead to this next slide while I ask the question verbally. So, which part of the brain is modified the most by the illicit substances as well as tobacco and marijuana? Which part of the brain is most modified by these illicit substances and feeds the addiction process? So you can use your chat to answer that question. Is it okay? All right. Gave you a big hint, right? It is the prefrontal cortex or the frontal lobe, right? That is our seat of emotions, and a lot of things are happening, and we've got a lot of dopaminergic, serotonergic pathways that are kind of going through there, okay? So I wanted to remind you, as we kind of wind down, the benefits of encouraging patients to stop smoking. So in the next slide, I think I show you just how quickly, if you get a person to stop smoking, the body responds as early as 20 minutes. It recorrects itself. And so we immediately start seeing respiratory benefits. And so there are both long and short-term benefits to encouraging that they stop whatever product for whatever reason. The important thing is that we play a really integral role in all of this. Now, one of the strategies that I wanted to mention, and unfortunately, we don't have a lot of time to talk about it as I would like, is motivational interviewing. And motivational interviewing actually has been used in tobacco cessation, etc. But I do want to show, if I can, show you a video really quick of it in action. And what it does is, while Dr. Jackson is queuing up the video, what it actually does is allows us to kind of do something similar to what Mr. Massey was talking about, where we promote behavioral change depending on where they are in the various stages of change. So let's watch this for a few minutes and then we'll come back and talk about what happened.
Well, Gail, it seems like you were doing really well on your antidepressants and that Dr. Jones has written you another prescription for 3 months. I'm really glad to hear that you're feeling better and that you're feeling really positive and you're back at work. But before you leave, would it be okay if we talked about your smoking for a few minutes?
Sure, I guess.
So the last time you were here, you mentioned that you've been smoking for about 10 years now and that you smoke about an average of 20 cigarettes a day. Would you say it's still the same or has anything changed?
And to be honest, it's a little bit less since I've been back at work. On a good day, it's about 10 now.
Oh, great. Well, I'm really glad to hear that you've cut back on your smoking. And I know that you told me you'd like to get back into running. And if you do end up quitting smoking, it is one of the best things that you can do for your health and can actually help you to reach your goal of getting back into running.
Honestly, it's something I think about quite a bit, not to mention the amount of money I would save. I am really nervous though about quitting because I don't want to mess up how I'm doing right now.
Yeah, I can understand that. On a scale of 1 to 10, how important is it for you to stop smoking right now?
Probably a 6 or 7 maybe.
Okay, so it sounds like you are interested and it is important to you. I have some information here that I'll leave with you that you can do some reading in, and it can actually help you, give you some tips and help you to develop a quit plan if you're interested.
Do you have any information on the gum or the patch? Maybe that would help?
Yeah, I do. And I'm really glad you mentioned that because medications like nicotine replacement therapy can be really helpful. They certainly help people and are effective in helping people to quit. But this information is really just a starting point for you. If you're interested, I can fill out a fax referral form to something called the Alberta Quits Helpline, and a trained tobacco counselor can call you back and actually provide you with more information and help you to develop a quit plan if you're interested.
Yeah, that sounds really good. I like the idea of them calling me. Not sure if I'm ready to quit yet, but I don't mind thinking about it some more and talking to someone.
Great. Well, why don't we fill out that referral and send it off, and I'll see you back here in 3 months.
Okay. So basically, she was lucky. She had a patient who expressed a willingness to do it, but she also noticed that this patient had been smoking for 10 years. So we don't want to let people smoke that long before we ask the question. So remember those 5 A's. And Dr. Jackson, could you bring the slides back up? And what I would love to point out is just a reminder. I have a visual cartoon that kind of just shows how individuals can be at various stages. So she says she wanted to quit, but then she was like, I don't know. I don't want to mess how good I'm doing up and that kind of stuff. So what you were seeing was the interviewer or the practitioner just embracing where she's at. And it's really very similar to that safe model where we want to encourage them, not judge them, but let them know we're here. You noticed how she slipped in and provided resources. She included things like the quit quit line, explained a little bit about what all that would entail. And I do want to say that the AHEC programs, when individuals do participate in the quit programs, they actually get those products free. So they have the choice of either the gum or the patch. And that would be something I would encourage you to also consider as perhaps something you do in your consulting practices. So this just kind of shows the 6 stages of change. And then I think in the next slide, I wanted to point out that you do have to, we'll skip that slide and go to the next one, yes, that there are some techniques and core components that actually are involved with motivational interviewing. But it does actually bring forth the spirit of collaboration, and autonomy for the patient so that they're in control. That's really the important part in the evocation. And we're there to provide support, not judge, but to kind of help them as they go down this particular journey. So I think I'm at the end of my time. I want to thank you all first for your patience, with the technology. I want to thank Dr. Jackson for being my Vanna White. If you have any additional questions, you can always reach out to me. Thank you, Dr. LaRose, for the opportunity to be a part of this program. And I hope you walked away understanding the challenge that we have with emerging substances. I hope you've learned a little bit more about why the addiction process is as challenging as it is and how mental illness can coexist, and some of the things that we can do as far as strategies in our patient encounters to really try to help patients navigate what they're going to do in terms of treatment. And then I also hope that you understand that there's resources out there for us. But at the end of the day, as pharmacists, we do what we do. We remind patients, depending on the formulation of what they're doing, how long they've been using it, and their other patient-related factors, that we educate them about the risks. We need to be aware of the benefits, right, and the opportunities, like with things like with medicinal cannabis, but that certainly we make sure we're paying attention to drug interaction potential and other things, and we recognize the signs and symptoms that suggest we have addiction issues going on and get them to the right treatment. So with that, I would, open the floor for additional questions. If there's anything else, I'm here to answer, and I'll be here on the remaining of the program. And thank you so much for this opportunity, and good to see everybody.